Hi, good evening, everyone. My name is Sierra, and I am the marketing coordinator here at Reproductive Biology Associates. I just wanted to say a quick thank you for hopping on with us today for the egg freezing and fertility preservation webinar. I do want to let you know that there is a Q&A function for this webinar, and you are free to utilize that whenever throughout. Just know that Dr. Toledo will wait till the conclusion of the presentation to answer any and all questions. So without taking up too much more time, I'm going to go ahead and pass things over to Dr. Andrew Toledo.
Thank you, Sierra. I hope everyone can hear and see me okay. I'm sharing my screen so that you can see the presentation. And obviously, like Sierra said, we're going to try to keep it straightforward. It's 5 o'clock on a middle of the week afternoon. We got a Braves game going on for those of you who are Bravos fans. Thank you for hanging out before you go to the game or go watch the game. And again, I'm going to try to keep it straightforward. I will open it up for Q&A at the end. So if you have questions, go ahead and fill the Q&A, and I will look at those and answer them as they pop up. So we'll start first by kind of just going through what we're going to try to cover here. You can see there are about 6 things we're going to cover, and I promise you we're not going to spend a whole lot of time on some of these areas because clearly we want to hit the things that are most important to you. Clearly, from an intro standpoint, this is who I am. I've been here a long time. As you can see, I'm the CEO of this office, of this clinic, and I work at the main office. And there are obviously other offices that we have in the RBA network that are shown here. And clearly, they're there for your convenience. If you decide to go through this process and happen to live closer to one of these offices, you can do some of your monitoring at one of the more convenient offices so that you don't have to drive down to the main office on a regular basis. We are located, again, around Northside Hospital, the main Northside Hospital office, what we fondly call Pill Hill. So that's where the procedures are done. So unfortunately, you will have to have the procedure done here, but monitoring blood work and ultrasound can be done at these other offices. This is my team that work with me, and clearly I have an excellent group of doctors that work with me and have been doing this for a long time. If you look at Dr. Naj, who's the one in the coat here on the far right, he is our embryologist that makes the magic happen. He is a phenomenal embryologist that does incredible work. So if we're going to talk about freezing of eggs, you should know that he's a pioneer in this area. We do a lot of things here at RBA. We do more than just egg freezing. We do all kinds of infertility treatment. We treat male, we treat female, we treat same-sex couples. We do, minimal type fertility treatment like IUI. We do surrogacy for couples that need to have someone else carry the pregnancy for them. We do genetic testing. And obviously we have women that serve as egg donors for couples whose the female does not have a good egg source. So obviously those are not things we're talking about tonight. So we're going to get right on into it. This is an amazingly expanding field. I can tell you from the patients that I see on a regular basis that more and more young women are deciding to do this as an alternative if for whatever reason they feel that there is a need to preserve their future fertility. The process of freezing has been around for a long time. In the thousands of years ago, various things were frozen for purposes of cryopreservation. Obviously, things didn't work out so well back then because the technology was not very good. And if you look at the rest of this slide, the first pregnancy achieved from sperm freezing, from sperm that were frozen, didn't happen until the early 50s. The first baby born ever from a frozen embryo was not done until 1984. We were able to obviously do some incredible things here at RBA in the early 80s. RBA has been around for 40 years. So we've been on the forefront of a lot of this technology, as you can see on the brag slide here. But I think the most important thing is the bottom right slide that talks about the technique of vitrification that we helped to develop back in 2007. Vitrification is a fancy word for fast flash freezing. Before this technique, unfortunately, the technique to freeze eggs was not very viable. We lost a lot of eggs. For every 10 eggs that we froze, only 1 egg survived. So survival was only 10%. Now, with this technique of fast freezing, we can see 80 to 90% survival rate. And so obviously we have a technique now that allows for a much better result. And that is a technique that our embryologist, Dr. Naj, helped to perfect. So much of this process depends on the age of you, the patient. It is important to know that the most fertile time for a woman, unfortunately, or fortunately, depending on where you are in this, is in the early to mid 20s. As women get into their early 30s, there is a drop off in fertility, as you'll see on that slide to the left. There is, if you look at the slide that talks about number of eggs frozen, you can see that, and this is for women who are age 35 or younger, it takes about 15 eggs frozen to get about an 85% survival rate or an 85% live birth rate, i.e. having a child with those 15 eggs. And this is obviously going to change as a woman gets reproductively older, as you'll see in subsequent slides. As women get into their latter 30s, early 40s, success rate will drop considerably. Now, who should consider egg freezing? Well, there are different reasons why you would do this. Number one, you don't know if you're going to have kids, but you like to retain that possibility. You may be in a work situation where your job, your working situation does not allow for that to occur right now. You haven't found the right person to have your pregnancy, your baby with. There may be medical reasons that you may decide to do this. I will digress a little bit and tell you today, my first patient was a 21-year-old patient who's certainly not ready to achieve pregnancy, but for whatever reason, she has diminished ovarian reserve. Her egg count is very low for her age, and she wants to retain her future fertility, and ergo wants to do egg freezing for that reason. So, of course, that's a very good reason to move forward. As I was alluding to, if you look at this slide, you'll see that the line graph on the left shows you that the number of follicles and the eggs that you have are in follicles begins to decrease with age, starting somewhere around the early 30s. And then by the time a woman reaches her late 30s, early 40s, there's a dramatic decrease in the number of follicles, ergo eggs. And also of note is the fact that as a woman gets reproductively older, the percentage of abnormal eggs goes up dramatically as a function of age. So it is, as the slide says, it is the age of the egg, not the age of the person reproductively, that determines the fertility potential. So if, for instance, you freeze your eggs at age 32, but decide you're not going to utilize those eggs until you're 37 or 38, the age of the egg at age 32 is the important factor here, because the success rate is going to be tied to the age at which the egg was frozen, not the time at which you are trying to achieve pregnancy. So that is important to remember, and that's why you would theoretically want to do this. So this is just a slide, a histologic slide that shows you what the little follicles that have the eggs in them look like at different stages of reproductive life. So you can see that the slide from a young woman at birth shows a lot of those little follicle units that have eggs in them. If you look at that same kind of tissue in a 25-year-old patient, she has a lot of little eggs there, but not as many as at birth. And if you look at a menopausal woman at age 50, you can see there's only like 1 or 2 little follicle units there. So clearly, this is what's happening along the age spectrum, is that women are losing their overall egg count over time. One of the tools that we use to determine where a woman is from an egg count standpoint is a hormonal level called AMH, anti-Mullerian hormone. Now, anti-Mullerian hormone is a hormone that actually is part of the embryologic process of you and of course of any person developing inside their mother's womb as they are progressing as an unborn child. AMH, anti-Mullerian hormone, actually is important in male development because it keeps young baby boys from developing female parts. So it is really important in having male structures form in fetal male babies. What's important later on is that this hormone is linked to the number of eggs a woman has at the time it is measured. Now, it is not an exact measurement, but we know that the higher the AMH level, the greater number of eggs that are there at the time of that measurement. So the higher the AMH, the greater the potential number of eggs. The lower the AMH, the less number of eggs. So the patient I was telling you about today who came in at age 21, her AMH was 0.76. If you look at the scale there, that's quite low. She should have a level somewhere in that 1.5 to 4.0 range. For those of you who are on this telemedicine or on this seminar, webinar, if you have what we call PCOS, polycystic ovarian syndrome, which is a syndrome in which women ovulate irregularly and have other characteristics like irregular periods and so on, usually the AMH level is higher. So that if we see a woman with a very high AMH of, let's say, 12 to 15, we know she probably has PCOS, polycystic ovarian syndrome. So again, this is not an exact measurement, but we use it to determine the kind of protocol we're going to use when a woman decides to do egg freezing. So the patient I was telling you about from today is going to use a very aggressive stimulation protocol as opposed to a more moderate, low stim protocol. So that leads us into sort of what happens if you decide to go down this path. So if you decide to go down this path, the first thing you're going to do is you're going to make an appointment with either myself or one of those other doctors that I showed you on the slide, because we're going to want to go over your history. We're going to want to go over your goals. We're going to want to go over anything that you've done beforehand. Like if you've had some of these levels done or ultrasounds done, we're going to want to see them. We're going to want to know, well, what are you thinking when, if you are going to have a family, are you thinking about 1 child, 2 children, a big family? Because of course that's going to affect how aggressive we are in going through this process. Women who want a larger family are going to think about needing to freeze more than maybe 10 to 15 eggs, like you saw on that slide about how many eggs it takes to have a child, a live birth. We're going to go over your history. Usually when I see a patient like the patient I was telling you about, she already had the blood work. She had done an ultrasound looking at what we call a basal antral follicle count. So if you go back to that slide that showed you the number of little follicles on that slide, that's what we're looking for on ultrasound. Well, obviously, it's an ultrasound and not a histologic slide from tissue, but we're going to want to look at an ultrasound as well as that AMH level to determine kind of where you are with your follicle count. And obviously, if you decide to do this, then we're going to have a protocol that involves starting you on medications that will stimulate the growth of these follicles. And like it says on this slide, usually the medications will start on day one. The medications will take you through about a 10 to 12 day process. You're not going to come in every day for blood work and ultrasound. You'll come in about 4 or 5 of those visits. Then you will get a final shot that triggers maturity of the eggs. And usually you'll have a surgery to extract the eggs about 36 hours after that shot. So if you have your so-called trigger shot that matures the eggs on the night of day 12, then you would be having surgery on the morning of day 14. And obviously that gives us time to mature the eggs after that trigger shot. So again, that's a very, cliff note version of what happens. But, going through the process, it sort of looks like this. What happens is these medicines that you're on are called gonadotropins. So gonadotropins are medicines that stimulate the gonads. Well, your gonads are your ovaries. For men like me, our gonads are our testicles. So for women, what we're trying to do is stimulate the ovaries to produce more than one egg. If you were, let's say, not on a birth control pill or some kind of hormonal medicine for contraception, and you were just on a regular cycle with nothing, stopping your normal cycle, your body would only let one egg produce. You would start off with a lot of little eggs there waiting to be stimulated by your brain, but only one egg would be produced and all the other eggs would unfortunately be lost in that cycle. What we're trying to do with the fertility shots is stimulate more of those eggs that are there at the beginning of your menstrual cycle so that we can get a greater number than just one egg. And these injectable medicines do just that. So you're on these injectable medicines that thankfully now are given sub-Q, that is subcutaneously, like an insulin shot or an allergy shot, as opposed to when we used to do this way back 30, 40 years ago, where all the shots were given in the buttocks muscle and the gluteal muscle, which of course is a more difficult shot to get. So you take these shots on a regular basis. We're monitoring you, like I said on the last slide. And then once you've taken the trigger shot, you can see from this slide that the process of retrieving the eggs from those follicles is done vaginally. This is a picture of a vaginal probe in the vaginal canal with a needle guide going into the ovary. And this is done under light sedation. So those of you that have had like wisdom teeth surgery or colonoscopy or something or maybe a D&C, the anesthesia is mild. It's given intravenously. The procedure takes about 30 minutes. There's no incisions. It's done vaginally. And usually, your recovery is quite quick and the next day you're fine. And so, it's a pretty straightforward, simple process. There are not a lot of risk of doing this procedure. The obvious risk is, and we learned this with our egg donors, was egg donors, when they would come through and go through this process and their eggs would be frozen for, anonymous use in a couple that unfortunately the wife or the woman didn't have good egg production. Some of those young ladies would unfortunately get pregnant the next cycle because we had sort of supercharged their ovaries and they weren't using contraception. So we recommend that when you're going through this process, if you're sexually active, use usually a barrier method of contraception like a condom in this process. The process of or the side effect of ovarian hyperstimulation syndrome, better known as OHSS, is a syndrome in which the ovaries get very large. There's fluid accumulation in the ovaries, in the abdomen, sometimes in the lungs. This happens incredibly rarely now, in less than 2% of our cases, because the medicines that we use to both stimulate the follicles to grow and to trigger are better at avoiding this process. So it's, as it says there, it's very rare when it does happen. Of course, anytime if you're going through this process with us, we're going to take care of you. We're going to follow you post-operatively. We're going to be available if you have any of complications or issues that you're worried about. And so, of course, it's not just do the procedure and you're done. We're going to make sure that you're okay through the entire process. The other complication is sometimes, for instance, the patient that I told you about, despite the fact that I'm going to be aggressive with her, she may get very little response, and I may have to cancel the cycle so that, unfortunately, we cannot do the procedure because her ovaries may not respond. We won't know that until she's on this. And this happens in maybe 7% of the cases. But if those of you on this, seminar, this webinar, have good AMH levels and good basal antral follicle count on your ultrasound, it's very unlikely if you decide to do this that you're going to get canceled through the process. It's more likely to happen in women who are older, women that are, greater than 37 years of age doing this, women with low AMH below 1, women that have low basal antral follicle count below 4. Those are some of the, situations where we may see that happen. So again, this is a pretty straightforward process. Obviously, once we have done the procedure and your eggs are frozen, you'll know before you leave the surgery suite how many eggs we retrieved that morning from your ovaries. Now, there is a difference between retrieving the eggs and being able to freeze the eggs. We can only freeze eggs that are mature. That means they have to be mature enough and developed enough so that when we freeze them, they will survive the freeze-thaw process. If the eggs that we obtain are immature, they will not freeze properly and they will not be able to be frozen. So if, let's say, we get 10 eggs from you on the day of the procedure, but the next day you get a call from one of my nurses and they say, well, out of that 10, only 8 were mature and we froze those 8. That's because the other eggs were not mature and we can only freeze mature eggs. Now, these eggs are going to sit in suspended animation. Once they're vitrified, frozen, they are in a state of suspended animation. And as long as they stay in that state, they can be used 1 year from now, 5 years from now, 10 years from now. They could be used in perpetuity as long as they're frozen. So obviously, you would then decide, do I need these eggs? Because let's say you do this and for some reason you decide, okay, I'm ready to get pregnant. You find a partner. You begin your attempts at pregnancy on your own. You get pregnant. You have your family. You may not need the eggs. They're there as an insurance policy in case you do need them. But if and when you are going to use them, we would obviously thaw them. They would be fertilized with whatever the sperm source is, your partner's sperm or donor sperm. And we would use a technique called ICSI, which stands for intracytoplasmic sperm injection. The reason we would do that is when you freeze eggs, the outer coat of the egg is called the zona pellucida. It's fairly rigid after you freeze it. It doesn't allow for normal sperm egg fertilization. So we have to bypass that little zona, that little outer coat, and put the sperm directly into the egg. And so obviously that's how we create a fertilized egg, better known as an embryo. And then of course, we're going to develop that embryo and either put it back into your uterus or a gestational carrier if y'all are not going to carry the pregnancy for whatever reason, for health reasons or for whatever other reasons. I saw a patient today who unfortunately has a disease process called adenomyosis, which is endometriosis of the wall of the uterus. And unfortunately, she's got some frozen embryos, but her uterus probably is not going to work in holding on to a pregnancy because of this diagnosis. So we're having to talk with her about using another person's uterus, a surrogate's uterus, which obviously is something you would do only if necessary. And again, you don't have to use your eggs. You can see there that there are options. You would either say to us, I want to discard them, let them go, or hey, I want to donate them to another person. If you decide to donate them, then obviously there are some processes that have to occur in that situation. It isn't just a simple handoff. Or you can say, hey, I want to donate them back to science to benefit, whatever I can, help science with in that situation. So those are some of the things that basically are done. But the majority of women end up using these eggs at some point. And to that point, this is a picture of our IVF lab. Dr. Naj and his embryologist work in this kind of environment. There's a lot of high-tech equipment in there. An IVF lab can cost $1 to $2 million to build out. So there's a lot of expensive equipment in that lab. And there's a lot of experience in that lab. We have embryologists in there that have, many, many years of experience. They've been extensively trained. And our goal is really very simple. Their goal is very simple, is to be as efficient at this process as we can, so that if you go through this process, you have, the best outcome for the future. One of my patients who, again, I like to give you examples. So real live people examples of this. But I had a patient who just came through. She works at a large corporation. She happens to have benefits, and she's 35 years of age, does not have a partner, and just came through. She had a very high AMH, and we ended up being able to freeze 42 eggs on her. She should not have to, unless she wants a very, very large family, she should never have to go through another egg freezing process, because, if her goal in this case is 2 children, we should certainly be able to make 2 children out of 42 frozen eggs. So she's an example, but our goal is obviously to be very efficient, to, have you get the best outcome, but to take care of you through this process. So that's another thing that I try to emphasize to my patients going through this, which is that, we want to take care of you. You're a human being going through a very emotional process. So it's not just cut and dry, and we want to take good care of you. Yes, it's pretty straightforward most of the time, but in this woman's case, the one I just told you, she was very intellectually very smart, but was very overwhelmed by the process and needed a lot more, working with my team to help her understand some of the processes that just didn't seem to come very easily to her. So, for some people, you'll get it very quickly. For other people, it may not come so quickly, and everybody's unique. So I want you to know that if you go through this process, we're going to take good care of you as you go through the process. And then again, of course, there are basically financial issues. Again, I'm happy to say that more and more women out in this, metro area are getting coverage for this. The young lady I was just telling you about had insurance coverage for this process. So obviously that's a big benefit for those of you on this webinar that do have insurance coverage, because clearly that's going to make it easy for you financially. If you don't, then we have options available to you, like this slide says, that may make it easier for you to afford this process. Because, when you take the medications, which are expensive, the monitoring of your cycle, which is, serial HCG or serial estrogen levels and ultrasounds, surgery to extract the eggs, the freezing process, it's an expensive process. It's certainly one that is not easily done if you don't have some form of coverage or help. And so these folks are here to help you with the process if you need financial help. And so normally what will happen is when I do a consult, the next step, if not that day, then within a week after the consult, is for my patient to talk to the business office, my business office, to kind of go over these things. And it's not a one size fits all. Here are three options that we have right off the bat, and one may be better for you than the other. But at the end of the day, if you're on this seminar or webinar, you're doing it because you have some concerns or thoughts about doing this process. And again, I've gone through this in a 30-minute presentation, but there's a lot to it. And if you go through it, there are things that when I sit down with my patients, I go through. For instance, a lot of patients, although the surgery is quite straightforward, don't realize, hey, you have to have somebody here with you on the day of the procedure. You can't call the Uber driver to come pick you up afterwards because you're going to be having IV sedation, and we want somebody with you that takes you home and makes sure that you get home safely from the procedure. Yes, it's minor surgery. Yes, it's minimal risk, but we want to make sure there's somebody with you as you go through this. The medications, by the way, do not have any long-term risk. You're not going to use up your eggs faster in doing this. It's not going to put you through menopause sooner. You're not going to have a greater risk of ovarian cancer, breast cancer, or any of the other female cancers. So you don't have to worry about that. I think the greatest, issue is that you have to be emotionally prepared to go through this. So whatever work you're involved in, I do not recommend that you go through this when you're at a very difficult time in your workload. For instance, if you do taxes, you don't want to be doing this procedure while you're going through tax season. If you're a lawyer, you don't want to be going through this while you're going through depositions or trying a case. Those are just easy examples, but clearly you want to do this when you have the ability to come into the office, get monitored, and have a surgery to extract the eggs. Thankfully, the in and out, coming into the office, getting your blood work drawn, ultrasound part is a very efficient procedure. So you're not going to be here for a lengthy period of time. You'll still be able to carry out your workload when you go through the monitoring process. On the day of the surgery, clearly, you're not going to go back to work after that procedure. So that's important. The patient I was telling you about wanted to go and have dinner that night with friends, and I highly recommended that she not do that because she had had quite the result, and when I was concerned that she would be sore and very uncomfortable at dinner that night. I mean, theoretically she could have, but I think I talked her out of it. I don't think she went, although I can't swear to that. So basically it's now in your court. I mean, I've covered a lot of information in a very short period of time. And what I'm going to do at this point is I'm going to release the screen, and I'm going to open this up to the Q&A that we talked about, and go to the Q&A. And I see basically two questions here, and I'll read them and make sure that we answer them. So one of the questions are there any medications that can affect the level of AMH? The theoretical answer to that is no. AMH is usually independent of medications. However, practically, I have seen that some patients who have been on birth control pills for a lengthy period of time, sometimes there's a mild suppression of AMH in that situation, so that if you measure AMH in a patient who's been on the pill for a long period of time, and then you take that same patient, you take her off the pill and measure her first, let's say measure the AMH after she's had a spontaneous period, the AMH may be a little bit higher, not dramatically higher, but that's the possibility. The next question is it harder to get pregnant naturally after you freeze your eggs? And the answer to that is no. You should not have any more difficult time achieving pregnancy. Now, clearly, if you do the procedure, freeze your eggs, and let's say you're 35 when you do that, then you wait to attempt pregnancy when you're 37, 38, there's going to be a natural decrease in your ability to achieve pregnancy just due to age. So again, that's a different situation altogether. But the answer to that is no. It should not make it more difficult for you to achieve pregnancy if you're trying on your own. The next question is, any restrictions on medicines you take during the process? Yes, there are certain medicines that we don't want you to be taking during this process. The big one these days, believe it or not, are the semaglutides. A lot of people trying to lose weight right now are on Ozempic, Wegovy, Mounjaro, and those medicines, which are fairly effective for weight loss, slow down the GI tract. That's how they work. They make women feel full, so women are not as hungry, so women don't eat as much. But when you're having this procedure, the surgery, that can be a problem with anesthesia. That can be a problem with complications as a result of the surgery. So there are some medications that we would, obviously not want you to take. That's the big one. There are probably some other ones that we wouldn't want you to take, but by and large, they're very few. And so we would just go through the medicines that you're on, and like the patient, again, it's funny you asked that question, but she is obese. Her BMI is like 43 or 44. She's 21 years of age. She's trying to lose weight. She's on Mounjaro. And when she met with our anesthesiologist today, he advised her to stop the Mounjaro like 2 weeks before we do the egg retrieval. So that's important. The next question is, could I discuss freezing eggs versus embryos? Yes, that's a great question. So obviously, when you freeze eggs, you're freezing an egg that has not been fertilized. When you freeze embryos, you are freezing an egg that has been fertilized and then frozen. Although theoretically, the success rate see, my questions just went bye-bye. Although the success rate is the same theoretically, if, let's say, you were married or had a partner and you wanted to freeze the embryos and just keep them for another time, so there you would create embryos, and we would freeze those embryos and then use them at a different time. I always tell couples or patients, look, if you've got a partner you're going to, make a baby with, then let's go ahead and create embryo before we freeze, eggs. So there isn't any real difference. The only reason not to freeze embryos is if you're not sure you're going to stay with that partner, because once the eggs are fertilized, that partner has a say in what happens to those embryos. So if, for instance, I hate to be, cynical, but you freeze embryos with someone and you break up, those embryos obviously are now, there's a decision that has to be made. Are you going to get to use those embryos? Is the partner going to have access to them? And again, I use the the Sofia Vergara result. I don't know if you were aware, but Sofia Vergara, before she divorced the Wolfman guy, Joe, whatever his name was, now they're divorced, but they didn't do any of this. She was engaged to someone, and they did go through an IVF process unsuccessfully. They had embryos created that were frozen. They broke up. The deal was they were supposed to destroy the embryos. He wanted to keep the embryos. So there was a fight over who got to keep, or whether he was going to get to keep the embryos. Because they had agreed to destroy the embryos before they started, that's what happened. He didn't get to keep the embryos, but you get my drift. It's better if you know that you're going to use the embryo, or you're going to create embryos with the same partner, then it's better to freeze embryos. But if you're not sure, you freeze eggs. Go back to the answer. Let's go back to this. Let's see. I saw a question about, okay, down here, I have endometriosis. Can you make retrieving eggs more difficult? Yes, it can make retrieving eggs more difficult. The ovaries, if the endometriosis has created large cysts of endometriosis, then that's a problem, because we have to go through or around the cyst of endometriosis to get to the eggs that are being created from the stimulation process. Now, we do it all the time, but it's tricky. And the other thing that happens is your response to the medications can be affected by the presence of endometriosis. Women who have endometriosis have a lower AMH and less egg number as a result of that. So yes, that is for sure an issue. And there's a question here, provide ballpark amounts for medications, rounds of retrieval and freezing will cost. So yeah, so again, do not hold me to this, because obviously that's what my business office does at a much greater, at a much more specific and direct amount. But generally, the cost of doing an egg retrieval and the medications and so on are around $8,000 is my understanding of the process. And of course, that's for one round. If you work with one of those other programs that I showed you, sometimes they have what they call a frequency round, where you get to do a multiple set of procedures for a lesser cost. So let's say if you sign up with one of those financial groups, and they have a 3-round program where, you know, doing 3 rounds separately would cost you, let's say, you know, what, $24,000 if you multiply 8,000 times 3. If you sign up for, you know, one of their bundle packages, it may be less because you're doing it as a bundle. But again, usually if you look at all things, and of course, once you freeze the eggs, then the charge for keeping them frozen is usually fairly nominal. We don't charge an exorbitant amount for holding your frozen eggs on a yearly basis. I believe it's usually around $600 a year to hold them frozen for a period of time. So not that that's cheap, but it's not thousands of dollars. Let's see. The next question is, if you go through one cycle, how soon can you go through another retrieval cycle? Usually I'm going to ask the patient to wait one cycle, meaning if you did a cycle, you'll have a period following that cycle retrieval, usually within about 10 to 14 days after the retrieval of the eggs. We don't usually want to use that period. We want to wait till the next period to give the ovaries a little bit of time to recover, to let cyst of the ovaries, you know, go by. So that's usually what you want to do. The next question is there any point in trying to freeze eggs or embryos at age 38 or 39? Sure. I mean, it's not like I've frozen eggs in women who are in their early 40s, mid 40s. I mean, I have to tell them that statistically the success rate is going to be much lower, but I do have patients who have done that. So clearly that's, you know, a possibility. So, you know, what I would tell you is you come in and let's check your AMH, let's see if there are any other issues, and then let's talk statistically about what those 38, 39-year-old eggs would mean from a statistical success rate relative to pregnancy. Next question here is, I have PCOS and endometriosis, so they will maybe cancel each other out. Well, there is some truth to that women with PCOS will have a greater response, and the endometriosis effect can be dampened to some extent. I do have a patient that has both, and her AMH is quite good, and she's in stimulation now, and she seems to be responding very well to the medication. So clearly that may work in your favor. Okay, so obviously I would do that. I think I have answered all the questions that, let me go back and look. Yep. Yeah, I mean, any other questions? Because I know I covered a lot, and I know that, you know, there's a lot to this. And basically, there are, you know, a lot to this. And this is what I would tell you is if you think that this is something you might do, even if you're not sure, you should come in and talk with us about it. Even if you don't do it, you should get the information you need, because what I covered is just a cliff note version of the process. And so when you sit down with somebody like me or one of my partners, we're going to go through this in much greater detail. So obviously keep that in mind, and don't like, for the one that asked me about being 38, 39, don't count yourself out. For those of you who have endometriosis or other issues, don't think that those are impossibilities in the process. You obviously won't know unless we try. So I don't see any other questions here. And so with that, I'm going to say thank you for participating in this webinar tonight. Again, I know that it's late, it's a Wednesday, and I appreciate you taking the time to be with me tonight. I hope that this has answered whatever questions you have, and I look forward to helping those of you that I may see as a result of this going forward. Take care, have a great night, and go Braves.